So having thought about acyclovir, that brings us on really to think about probably the most significant disease and one of the most significant pieces of medicinal chemistry of my lifetime anyway, and that's HIV AIDS. So obviously HIV AIDS was an originally untreatable sexually transmitted and bloodborne virus which leads to death within a 10-year time frame. There's still no vaccine for HIV AIDS. Obviously HIV is the virus, AIDS is the syndrome into which the virus will turn, well, it's not the virus changed into it, it's the effect it has on your body if the virus goes untreated for a long period of time. So HIV AIDS started in the 80s, as we're going to see, and they just discovered acyclovir and found it to be active against herpes in the decade before. So the very first thing they did in the HIV outbreak was treat all the patients with acyclovir. But it was shown to slow the onset of full AIDS only in about 20% of patients. So it was considered not very effective as a drug. 80% of patients showed no benefit from acyclovir. But it was exactly the way that medicinal chemists were thinking about this disease. There was this rational approach to treating viruses using nuclear-based mimetics, and a lot of those have been developed as potential anti-cancer agents. And so that encouraged people to go and look for these kinds of drugs. Anti-nucleoside drugs were the obvious starting point because they're to some extent rational, so there was some understanding as to how they might work. And really the major breakthrough drug for HIV AIDS was AZT, azidothiamidine. It still is sometimes used as part of the triple therapy against HIV that we'll talk about. It was originally synthesized in the 1960s as a potential anti-cancer agent. And really this was the first drug that was capable of treating HIV and limiting the infection to some extent, and it helped to change the notion of what HIV was as a disease. We'll look at the structures in a moment, but probably you can already see what's going on just by looking at them. It's not so complex. We'll talk about the timeline first of all. So in 1981, HIV AIDS was first recognized as a disease, and that was in San Francisco. San Francisco had the twin issues of having both quite a large homosexual male community and quite a large drug-using community as well. And both of those things are elevated risk factors for transmission of the disease. And San Francisco is where it was first recognized. There were clusters of patients. In 1984, it was demonstrated that the HIV virus was confirmed to cause AIDS, because at that stage, of course, they were only really seeing the symptoms, and the symptomatic part of HIV AIDS was really when the patients reached the AIDS, the autoimmune deficiency syndrome. They picked up pneumonias and all sorts of other things, and tracking that back to realize there was a virus underpinning it all was rather tricky, but they did that quite quickly. In 1985, AZT was shown to be active in vitro. In 1987, AZT was approved for use in AIDS patients, so those in the final stage of the disease, although for many of them it was already almost too late, the damage to the body was too great. And in 1990, AZT was approved for HIV positive patients. And the reason for showing that timeline is not so you learn the dates, it's not the point really. The point I want to get across to you is that that's the fastest route to clinic ever for any drug. Normally, you go through full sets of preclinical trials, you do phase 1 trials, you do phase 2 trials, phase 3 trials, a process that's explained at the back of this handout. You check safety first and all sorts of things. All of that was skipped for HIV AIDS. They went straight into treating patient groups. And that's because on ethical grounds, if a group of patients is dying of a disease with no treatment, you can ethically test things on them that haven't been safety checked in the same way. Okay. So let's just look at how the drug works. I'm hoping you've been sitting thinking about it, but it's very, very similar that you have a DNA base. This time it looks like thymidine. AZT means azidotymidine. I don't know whether I wrote that down, so azidotymidine. And you can see that where there should be an OH group, you have an azide, and so you've blocked the replication of the DNA down through there, whereas in normal thymidine, you grow the DNA chain through those two OHs. So it's exactly the same principle, just different chemistry, and this one works better in HIV AIDS than the acyclovir system. So as it says, this was one of the fastest routes to clinic for any drug in the modern era. In the first clinical trial, 9 out of 140 patients from the AZT group died, and 32 from the placebo group died. And at that point, the trial wasn't finished. They closed the trial and all the patients were given AZT. Once they had those figures that it was nearly 4 times as many dying with placebo, they went to all the patients on both wings of the trial, they unblinded the trial, and they gave them all AZT. And so, again, that kind of shows that you can change the ethics of a clinical trial when there's a life or death situation. So, the mode of action, we're just going to go into a little bit more detail now. AZT, like acyclovir, mimics a DNA base and prevents viral replication. In particular, it inhibits reverse transcriptase. This is an enzyme. I'm going to say a bit more on this page. The figure's overleaf, but don't worry about it. I'll just put it here for now. There's a key process. This is the HIV virus outside a cell. HIV is an RNA virus, and one of the first things that the HIV virus does when it gets into your cell is it undergoes a process called reverse transcription, where it turns the RNA in the virus into DNA. So that's backwards to what normal transcription is. So the RNA turns to DNA with reverse transcriptase. And just to note that for you turn DNA into RNA in transcription, of course. And I guess it's worth saying that another really important enzymic process in HIV is integrase enzyme. Integrase integrates the HIV DNA into the host cell. And then ultimately it replicates. And so AZT inhibits this first step, the reverse transcriptase step. So if you look over the page, that's what this image is showing. It looks quite a complicated life cycle of the HIV virus, but it's doing what I said all viruses have to do. They use your mechanism and machinery to replicate, but they add a few enzymes in of their own to allow them to make use of your machinery. And it's those different things that they do that become the targets for potential therapies against the virus. So, looking in particular, at this same life cycle, you have the reverse transcription step here. That's something unique. The virus is doing it, but your cell is not. That's what's turning the RNA into DNA. What's happening here is that you've integrated the DNA for the HIV virus into your own genome. So you now have HIV DNA in the genome. And this is done by the integrase enzyme, which again belongs not to you, but to the virus. So again, that's a target for potential therapy. Then, that DNA, once it's integrated, just uses the mechanism of your cell. It generates RNA and messenger RNAs, and it generates proteins, and it begins to make a copy of itself. There is a key modification step here, done by protease enzymes from the HIV. So that's another HIV enzyme because it modifies your proteins, it modifies its own proteins, in a specific way. And then it does an assembly process that's budded into the cell membrane, hops out, and goes off to infect other cells. So that's the life cycle of the HIV virus within the cells. This is also why once you're infected with HIV, it's not something that you can ever remove fully from the body because the DNA is integrated into your own cellular DNA and will replicate with your own cellular DNA. And this is why therapies now focus on undetectable levels of HIV, which means you have no mature HIV coming out of any of your human cells, which means you've probably inhibited perhaps 1, 2, 3 of these processes, and we'll talk a bit more about that in a moment. And that's what HIV therapy is all about, is zero of this, because this is essentially what is infectious, and what's within your cells is not infectious. Okay? And many viral issues work the same. If you've had chickenpox virus, the chickenpox virus stays dormant in your body also for long periods of time and can reactivate and become shingles in later life. Okay? It's a virus that you never clear fully from your system. Many viruses do this, integrate permanently into your system. It's worth saying, having talked about AZT, that if you go and read about AZT online, you'll think it's the worst drug in the world, and it's been controversial. There's all sorts of things been suggested about AZT, mostly people saying it's toxic and kills patients. And if you read all the stuff online, it says, oh, there was never a proper clinical trial done on AZT. It was just rushed to market, and there was no proper testing done on it, and it's not safe. And the truth is there was testing done, but it was closed early. It's also true that the doses of AZT given in the 1980s were much higher than the dose of AZT that you would get if you were on the drug now that there's triple therapy available. So AZT as given in the 1980s definitely was more toxic than the AZT that's used with patients now. The campaigners have said AZT failed cancer trials because it was too toxic to use. Now, it's true that AZT was a failed cancer drug, but not because it was too toxic. It failed because it was ineffective against the cancers they wanted to use to treat with it. And also the doses being used for cancer treatment were very different to the doses being used for HIV treatment. So all I'm saying is it's a morass when you go out onto the internet and look up about HIV. But the key thing is once AZT and the other key drugs were introduced, this is what happened to the rate of death of HIV in America. Hiv Aids and the deaths that it caused. It was a very, very significant development. Actually, you can understand why people feel so strongly about it. You know, I was in San Francisco and I was sitting in a bar having a drink in the Castro, and there was this guy, he was about 80, and I always get hit on by 80-year-olds. And he was chatting to me, And he'd lived through the whole HIV thing, and he was absolutely convinced, there was no shifting his opinion on it, that the whole HIV virus had been developed in a lab by the government because the government wanted to kill gay people, and then it had been released. And then he was convinced that AZT was this super toxic drug that they'd had waiting so that they could give it to all the gay people and kill off all of those that the HIV virus hadn't got. And he was absolutely convinced of all of this. There was no persuading him. But he'd watched 80% of his friends die of HIV in the 1980s and the 1990s. So in many ways, it's not surprising that people have some of those attitudes. You know, we had Carolyn Bertozzi visiting the department last year. She's one of the biggest chemists in America. She works over in Berkeley in San Francisco, and she was there through the 1990s and volunteered in the AIDS clinics. And she said it's one of the reasons that she became so interested in glycobiology and understanding sugar chemistry on the surfaces of cells and viruses, because she saw all these people dying of HIV, and her approach was to want to understand the sugar chemistry that goes on, that mediates the interactions between things like the viruses and the human body. Everybody responds to those kinds of massive personal events, I think, in quite different ways. And in some ways, it's understandable that some people just want to get angry about it in a way, irrespective of what they turn their anger against. It is also true that if you only use AZT on patients, ultimately it's not any good, and the patients develop resistance to AZT quite quickly. It's actually one of the less good of the anti-HIV drugs. And so quite rapidly, after the development of AZT, a whole range of structurally similar nucleoside-based reverse transcriptase inhibitors were introduced to the market. And these were designed to avoid problems of AZT resistance and improve on its performance. So there's now a whole family of AZT-like drugs, and many of them are better than AZT, and they do have better toxicity profiles than AZT. If you take PrEP, which is pre-exposure prophylaxis, which is particularly used, I guess, at the moment in the gay community, and it stops you getting HIV in the first place, is the idea, because it wipes out the virus before you get infected with it if you're exposed to it. That is based on a pair of nucleoside inhibitors called Truvada, is what it's officially marketed as, and you can go look up all the details of that online. But just relying on nucleoside-based inhibitors, if you've got HIV, is not good enough. You need to attack more bits of the viral life cycle so that more of the virus will be killed. And I've already hinted at that, and that's what leads to multi-drug therapy for HIV AIDS. And generally speaking, multi-drug therapy for infectious diseases is becoming a seriously thought-through way of treating them. So typically, if you have HIV, you'll take 3 different drugs now. So I'll just show one of them here. The next most important class of anti-HIV drugs are the protease inhibitors. They stop this modification process, which is chopping up some of the proteins that have been made from the HIV virus. Protease enzymes play an important role in hydrolyzing proteins ready for the assembly of new viral particles. Inhibiting this step can limit infectivity. Saquinovir, the protease inhibitor, was first approved in 1995, and it was paired with AZT. So these were the first 2 drugs on the market, AZT and Saquinovir. And at that point, you were attacking 2 different bits of the HIV life cycle, and the treatment was a lot better. Again, it was rushed to market because of the very poor state of the HIV epidemic at that stage. So this drug inhibits HIV protease 1. What that does is it's a protease, so it obviously hydrolyzes amides to carboxylic acids and amines. And I'm not going to go into a lot of detail about the mode of action, but suffice it to say that this bit of the molecule looks like a bad peptide bond. It's clearly not a peptide bond, but it has a very similar, once you've got all the bits on, it has a very similar geometry and some electronic density. And what it does is it binds to and inhibits HIV protease 1. So that's a protease inhibitor in very limited detail. Integrase inhibitors reached the market in 2012 and are of increasing importance for treating HIV. So that's the third specific thing about HIV that you can consider doing. And so a very modern HIV therapy might include a reverse transcriptase inhibitor, a protease inhibitor, and an integrase inhibitor. They'll shift therapy around if you have HIV over time, so you might sometimes be on 2 reverse transcriptase inhibitors and 1 protease inhibitor, then they might take one out and replace it with an integrase inhibitor for a while, and so on. Obviously, it's the treatment of an infectious disease. There is the risk that resistance will emerge within the HIV virus to any or all of these therapies over time. So although the situation looks good for HIV patients currently, you have to think forward that it's important to keep developing new approaches for the treatment of infectious disease, because if, like bacteria, you step back and you say, well, that problem's solved, we don't need any more antibiotics, then 40 years down the line, you come to the situation where resistance is quite widespread, the drugs are beginning to fail, and nobody's invested money in trying to improve it, which is what we talked about in the last lecture.